We heard already what defines youth. I think we have to start with that. Otherwise, we start creating arbitrary definitions of youth that don't represent youth at all. I like this photograph because the position is pretty similar. If you look at this over about a 20-year time gap, it looks like the brows are hanging, it looks like the skin is hanging, it looks like everything is gravitational in nature. But if you look very carefully and measure everything, the brows are relatively the same height. The eyelid skin on the right has probably fallen a short distance, but it also has gone up a little bit on the left. So there isn't a significant gravitational component to an area that looks extremely gravitational in nature. And if you look more carefully, you can see the bone exposure around the rim, and that's really everywhere, from the anterior cheek, outer cheek, into the chin. And a lot of times, though, that from this 20-year time gap, women don't necessarily want to have this much fullness or baby fat of our teenage and early 20s. So if you look at this photograph, you can see in a very short time frame, over 5 years, there's already more deflation. If you take that model, you begin to see that really, I look at aging sort of like a glass of water emptying. There's this ongoing evolution of volume loss. But there's also other changes in volume gain as well. So we're going to talk about a little bit about the gestalt of looking at a face. And we're going to talk principally here, of course, about volume. The other issues are covered very well today. So we're going to talk about what instantaneously, when you see a face, does it read for you youth? Is it a wrinkle? Even if someone's about 20 feet away, you look at them and you can already see that they look youthful. So what is it? It's about an overall shape. You saw earlier, the earlier talk, that just a blurred image, you can already get a sense of where that aging is. And I think in youth there's a lot of baby fat. If you think of that glass of water emptying, you start to see that we have a lot of baby fat, and just that fat is just an evolution of loss over time. As we go into our teenage years, there's still a lot of baby fat. We get into our early 20s, a lot of baby fat. And we just continue to lose fat. It's just this evolution of fat where you're starting to slim down into our mid to late 20s. And then as we get into our 30s, a lot of women say that's an ideal. When they pass 35, 40 years of age, they don't necessarily want the amount of volume when they go back and look at their photos in their early 20s, which is very interesting. So there's almost a triangulation to the face. As we get older, the dominance of the lower face starts to become more obvious, and I think there's a squaring effect, almost a masculinization. And a lot of times overlifting can further masculinize the face. The idea is that as we gain weight, as we get older, metabolism slows down and our lower face starts to dominate. Our attention moves away from the face, from the upper face, and it starts to go down to our lower triangle, which is exacerbated by further aging. And as you start seeing much older aging, the periorbital hollowing and accentuation of the jawline and the jowl region starts to create a full lower triangle. So the goal is to invert the triangle. Some of the subtleties that I'm going to talk about today in evolution over the last few years is to sort of think about more of an oval. And that really means understanding the buccal area. And we're going to talk a little bit about what that means. The ideal beauty in New York Times last year, they had an article, was someone in their early 20s, almost this sort of, prepubescent to pubescent look, or even late teens, or that whole period of time. Oftentimes, if you talk to their patients and you use those old photographs and dialogue, it may not be the ideal. So what is it? We talked a little bit about facial shape, and I think if you start to read that, and when you go back and look at those old photos, and you go with an instantaneous evaluation, you're going to start seeing that the facial shape is huge. And I think that, implants work very well, but you got to be careful, because if soft tissue is a principal mechanism by which there's loss in the face, an accentuation of bony landmarks through using implants may not be the ideal, especially around the eye region. And I think what's really important to start out with is a patient re-education, re-evaluating the patient and having them not go through their laundry list or their catalog of concerns, which are eye bags, wrinkles, folds, gravity, over and over again. And the reason for that is that when we talk about anterior chin hollow, transition points across the cheek in the buccal region, they don't know that, and that's because it's not in their vocabulary, and it may not also be in yours. So the goal is to sort of re-look at the face from a distance, because I always talk about that understanding the blink effect of just seeing a patient from an instantaneous perspective. If you see someone else, you see, oh, that person looks good or bad, even at 20 feet. So we got to get away from the very microscopic evaluation of our own faces. And so this is something that Mike Nyack, a surgeon out of St. Louis, came up with. I think it's a really nice way of thinking about this, which is, in youth we're a grape. As we get older, we become a raisin. Why stretch it and pull it into a pea? We just need to make people look like themselves, which is reinflation. We're going to talk a little about some technical pearls, how to do this safely. Obviously, experience and conservatism are watchwords when we work with this. The easiest place for me to harvest are the inner and anterior thighs and lateral thighs when a patient is supine. I do my procedures under general anesthesia. It makes things much easier, not have to reposition the patient. And I just use a harvesting cannula where I'm using 2 to 3 cc's of negative pressure there. The idea is that there's many ways to skin a cat. I know people that centrifuge, I know people that wash it, and there's a lot of dogma into, oh, you can only do it this way. And I see a lot of longevity with a lot of different techniques, so this is not meant to be absolute by any stretch of the imagination. And the tulip cannulas, I don't have any financial affiliation with them, works very well for me. I've used all the cannulas and they all work, I think, very well. The goal here is to be careful. We're going to talk a lot about it is sort of long-term changes with fat and being very, very careful of not trying to overstuff a face. You can create a very fat face and make something look very unattractive over time. And we're going to talk about understanding where those changes occur. The other thing that's important is something that I really like talking to some colleagues, and it came up with my idea in Vegas just a few months ago, is that fat is like cottage cheese. In other words, it's very soft. It doesn't have the ability in most cases to augment a fold or a crease very well. And then what you start doing is stuffing a face to try to lift these little creases or folds, and I think without much success. It's a very soft contouring capacity, and I use Restylane and Perlane and other modalities to manage lips and lines more than I use fat for those elements. Although obviously a lot of people can show very good results in those two areas. I just find that the predictable nature of putting fat into lips and lines, where traditionally people have put it, has not been as successful in my hands. The goal is not to look at the whole world through a very narrowed, constrict paradigm, but also understanding that there may be a role for a facelift, there may be a role for other things. And like Dr. Lambros, I don't do a lot of brow lifts anymore. And I really believe that a conservative upper bleph, possibly adding a transconj bleph when there's a significant steatoblepharon, is a very helpful thing. I would say about 80% of my lower eyelids are fat only, and I would say the remaining 20% are fat plus maybe a transconj. I don't remove skin just not wanting to get any of the risks of changes in the eyelid shape. The book that I wrote a few years ago with the Glass Golds talks about sort of understanding this through a cookbook formula so that you can approach this without fear. And the idea is to start slow and just do a very simple foundation work on the face and then building from it and then moving to areas of higher morbidity. These are some of some of the drawings for the book, just to go through some of the areas that in those 3 stages of treatment. The fat grafting is a very tactile skill. A lot of times you don't quite see the plane you're in, you feel it. And so this is where I sort of break it down into a deep supraperiosteal plane, into a medium plane sort of in the mid-subcutaneous SMAS region, and then in the very superficial area getting closer to the dermis. In the rim, I just stay very deep. I think that a lot of people I've talked to have had long-term issues when they get really close to the skin and they really try to get close to the ciliary margin. I don't think that, if you certainly don't have long-term problems with that, then that's great. I've become very cautious talking to my colleagues about doing that. I stay very deep, and the thing that I like is to try to go against the rim perpendicularly. If you try to attack it from a lateral side, I think you have a much harder time creating a result that's safe. And the refinement, I would say, as I move over, now what I've been doing is more and more entry points across the lower lid. As the rim is angular in nature, as I go over to the lateral canthus, this photo is actually a little out of date. I'll go all the way laterally and aim toward the lateral canthus. Really, where I'm trying to think about the face from an aging perspective is an idea of transition points. And I believe that unifying the transition from the upper eyelid brow to the lower eyelid is that juncture of the lateral canthus, and even further laterally, I'll just swing my cannula and enter laterally to create almost a unified upper eyelid brow. So limiting the transition from a distinct upper and lower eyelid is one of the refinements I've made in the last year. The nasal groove, I don't put a lot into it. I put very little, probably 0.2, 0.3 cc's. I don't like putting a ton of volume into that area. I just want to be conservative. The brow, to me, is an extension of the upper eyelid. I really look at it as a confluence. Again, thinking of zones of transition. So a lot of people distinguish that as just saying putting fat up here, but I also like just transitioning all the way up to the upper eyelid itself and allowing you to see that break point where the skin hangs over the orbital rim and goes into that cavity. I like to transition over the area, and I think it works well. The predictability in brow augmentation is not always there. Sometimes you get a little lost in that region. The anterior cheek, I think the main key is when you're going across regions that you need that have linear defects, it's much easier to approach it from a perpendicular perspective. So as you know, the malar ligament runs in this direction. I find it much easier to approach it by depositing fat perpendicular to the malar ligament and building it up in that plane from deep to superficial rather than parallel in nature. The lateral cheek, I do really, as you start to do fat grafting, your art begins to become more heightened. You start to see all these little places. So it's not just throwing some fat in the cheek or throwing some fat under the eyes. These little tiny areas start to become more and more important. And to me, I look at the cheek as anterior cheek, lateral cheek, central buccal zones, areas where there's a little dental hollow, I call the medial buccal hollow, the subzygomatic region where you get hollow, and you start to see all these little transition points, and you start to see negative space. So we're going to talk more about that in a moment. The buccal area, as I said, is not just one area. It's actually multiple small areas, and I really see a lot of almost two elements of depression across here, one underneath the lateral malar eminence and one in the central area. And then there's this one that oftentimes sinks in when there's dental hollowing. And so rethinking the buccal area is not just throwing fat there, but really seeing before you're treating. The pregial sulcus is an area that has a three-dimensional cylinder. There's a component that falls below the mandible we heard earlier, not just anterior to the mandible, and then going around that entire confluence. So really looking at it as three cylinders, one in front of the mandible, one underneath the mandible, and then a transition point between the two. So framing the eye, it's almost the antithesis of traditional blepharoplasty, which is instead of taking away, is adding. This is a conservative upper eyelid, plasma skin resurfacing, and a fat transfer. And you can see that what looks so clearly as a brow ptosis may not be if you just add a little volume around the right places, under the eyes and around the, that's how I manage skin issues under the lower eyelids, resurfacing and Botox rather than cutting, just to be absolutely conservative. This is my mother, about 2 years out from fat transfer. She also had a transcondylar lower bleph, and you can see that. It was interesting, I was looking at some of her old photos, and her brows are actually fuller and lower in some of them, and so there's this hollowing where there's a recession of the fat and skin upwards into the brow orbital rim. This is a lady that had a blepharoplasty and upper eyelid on the left, and you can see this very vacuous look at 41. For example, this woman who's had a brow lift and facelift has a very, very large cheekbone. So what I did was to de-emphasize this, is focus on the anterior cheek and focus on the central buccal zone to bring that into harmony with the lower face. And this is a great example of lowering the jawline just with fat. And this is a lady, if you look at her old photograph, you can see the transition of the cheek into the buccal zone into the anterior chin, which creates a very soft look. This lady here, you can see a lot of correction in the lower face as well, and some lip enhancement, and a little bit of upper eyelid bleph. You can see the balance of the upper cheek into the buccal zone, into the anterior chin. Restoring identity, people that have been overlifted. How do you unlift someone? When you put volume back in. This is a lady that had very large cheek implants, and I took those implants out and then sculpted the face. It's certainly not perfect, but it's bringing that buccal zone into harmony with the cheek. So just don't think you need to have a large cheek. There's a lady with a very over-articulated brow, and just focusing on that transition point over the orbital rim, you can see that the brow just doesn't look quite as heavy, quite as high, and you bring it down a little bit with volume, creates very good balance. There's a lady here that didn't want to have her cheek implants removed. Obviously these are large ones. People that use cheek implants probably use much more conservative ones and not positioned this way. And this is just adding volume back around the eyes, the cheeks, and the chin, and to offset the implant. Evolution of volume, what occurs with fat over time? And what I've really started to see is that fat doesn't have a linear change. It looks too swollen, then it dips, and then you're tempted to go back and add more fat, and then it actually gets better. And I use a model because I do a lot of hair restoration, and you'll hear my talk in a few moments, and this is where I've been thinking about it. And so what you see initially is you see a gross amount of edema early on. And then there's this dip that may or may not occur, and then there's improvement over time. And then over about 3 to 4 years, there's a little bit of dip, and at that point sometimes I use a little Restylane just to touch it up with one syringe. So the concept is why. And so I've looked at hair restoration as my model, and what I found, which is really interesting in Unger's book, is that through a process early on of primary and secondary inosculation, you have some degree of hold of the fat, but the fat is not very, very obvious. At 3 months, when the fat cells can shrink a little bit, you may get a more obvious dip. Obviously, what's different from a hair restoration is there's no hair growth early on, but the fat, the edema that's there, can mimic volume. But as that starts to subside, you start to see changes over time where the fat actually matures and gets better. And I think that break point is about 6 months. It's extremely similar to a hair transplant. When neovascularization is established around 6 months out, you start to have ongoing improvement up to about 18 months. And that's where I want to sort of walk you through some photographs to show you this probably more graphically. This is a lady at 48 years old who had some IPL injury. She had some facelift to try to rectify that, didn't succeed. This is a fat transfer at 1 week with some bruising. This is at 1 month, slightly cheeky, slightly full, but not too bad. And then at 3 months, that actually is not much dip. I'm going to show you some people that dip and don't dip. And I actually think she has a slight dip at 6 months where there's a little bit of a drop. But the temptation at this point is, oh, my fat is going away. Let's go back and stuff that face with more fat. And I think you get real problems down the road with that. And so if you look as we follow forward, 11 months, it's restoring itself. And then at 15 months, it actually looks about right. And I see a cap point between 18 months to 2 years. Just like when I do hair restoration, I see a lot of changes with that, where sometimes the hair looks the best at a year, sometimes it looks best at 18 months, sometimes I see already a vibrant growth at 6 months, and sometimes I see a vibrant growth at 3 months. And that's evolution of understanding a micrograph. This is a 40-year-old lady. This is a week out, a slight degree of bruising. It looks more youthful, but it's quite full. This is a significant dip. This is one of my most significant dips at 3 months. And the temptation is to see this and go, my fat didn't work. Let's go back and stuff more fat in there. I think that's a real problem. And this is about a year later, and you can see almost, and this is all taken with the same camera, same distance, same lighting, in the same room with no ambient lights and no flash. And it shows you the idea that there's changes over time. This is a lady that is 1 month out from a fat transfer, not bad. And I don't think she goes through much dip at 3 months, and not everyone does. But if you don't prepare your patients at 3 months for a possible dip, you and they will be doing some more fat transfer, which would be very dangerous. And this is 9 months out, and it's starting to blend, 1 year out, and then 2 years out. And again, this is not multiple touch-ups. This is not wrestling. This is not anything else. This is one single fat transfer. This is the book I wrote, and I appreciate your time today. This is my contact information if you need it. Thank you.